Good afternoon. We're live. It's Thursday, April 23rd, 2020, and this is the weekly healthcare provider webinar presented by the New York State Department of Health here in Albany. This is Dr. Elizabeth Dufour, Medical Director of the Division of Epidemiology at the New York State Department of Health. Joining us this week to update the healthcare workers with our latest guidance on COVID-19 is Dr. Marcus Friedrich. Due to the large amount of interest in our weekly COVID-19 guidance updates, we are offering a few different ways to listen to this webinar live and on demand. The audio and slide deck can be seen on YouTube Live. Point your web browser to coronavirus.health.ny.gov/weekly-healthcare-provider-update. The YouTube Live player is on our healthcare provider's webpage. It's mobile friendly, so you can watch right on your smartphone or tablet. An on-demand version of the webinar is available via YouTube. Go to coronavirus.health.ny.gov, click on the provider's link at the top of the page, then click on Weekly Healthcare Provider Update. It's available immediately after the live webinar concludes. The weekly healthcare provider webinar is also available as a podcast. Search NYSDOH or Healthcare Provider COVID. The podcast feed is updated by Friday morning, and the show notes will contain reference links and other important information discussed during the webinar. Today for the agenda, we'll review a number of updates on COVID-19. As usual, we'll go through the global, national, and New York State case count updates and healthcare utilization updates. We'll go through updates in the testing realm, containment and community mitigation, infection prevention and control, guidelines on therapy, healthcare system surge response, resources available, and a pre-planned question and answer session as a chat box is not feasible with the level of attendance. We have used information that you've provided to our email inbox with questions that you have to guide today's agenda and the pre-planned question and answer session. Upcoming calls will again be weekly on Thursdays, 1 to 2 p.m. And again, for folks who are not receiving these notifications, please work with your Health Commerce Systems site coordinator to receive notifications for the IHANS or Integrated Health Alerting and Notification System. A link to this is also available on the New York State Department of Health COVID-19 Healthcare Provider webpage that's available at the top of this slide. And again, the situation is rapidly evolving, as is our understanding of this new virus. So all of the information presented is based on our best knowledge as of today. So to briefly review some of the case counts as we've progressed along with this outbreak, many of you are aware of this, but just to give a snapshot here, the global picture has progressed with now over 2.47 million cases confirmed globally and over 169,000 deaths. You can see here that the Americas accounts for a significant portion of this, and as many of you may have heard in the lay press, the United States has the largest burden of any country globally at this point. This has not changed from the last 2 weeks, so I will not spend much time on this. However, please note that globally, the slide coloration is consistently colored as level 3 widespread transmission globally. And so this continues that CDC does not recommend that travelers engage in any international travel at this time due to a global level 3 travel advisory. Now we'll see here the situation summary in the U.S. Total cases are now over 800,000 and total deaths over 44,000. Although we are seeing continued increases as noted in this chart with a cumulative case count nationally, that increase has slowed since last week's webinar presentation. So we are seeing a decline in the rate of increase. And now for the New York State numbers. Again, these are all available on our website, listed on the New York State Department of Health COVID-19 tracker, where there's a lot of information available in an interactive format, and it can be adjusted based on different time frames, counties in New York City or outside of New York City. So first, in looking at a heat map here, we see where we have the highest degree of positives in the downstate region, with pockets surrounding Erie County, Monroe County, Albany County of increased positivities. Total persons tested were now at almost 670,000 persons tested in New York State since the start of this outbreak, with a total tested on the 21st of April, over 20,650 individuals tested. Out of those, how many tested positive? We are now at over 257,000 tested positive, and just on the 21st of April alone, over 5,500 positives. We can see here the daily trends throughout the course of this outbreak, or an epidemic curve or an epi curve. And the daily trends show the number of tests and number positive per day. So note here the percent positivity. We have seen some decrease somewhat to a current statewide positivity of 27% of those tested. And at some points during the peak, at the very end of March, we were at around 50% positivity. This can again be viewed for different time periods and different locations. Sadly, we have now reached over 15,300 fatalities. And the next slides reveal data for fatalities, both statewide and again available by county. Notable findings include in New York City, those identifying as Black comprised 28% of fatalities, while only consisting of 22% of the population. Outside of New York City, this is 18% of fatalities, while only consisting of 9% of the population. So again, we are tracking health disparities of this kind in order to inform assessments and health equity work on both race and ethnicity measures. These are not as severe as some other nationally reported numbers, but still of significant concern. Fatalities by gender are also available here, and again, a predominance of male fatalities is noted, consistent with other literature and information from other countries. And so here we see that the male sex is accounting for nearly 60% of deaths. Fatalities by age group reveal 84% of fatalities in those aged 60 years or over. And if we look at age 50 and over, it's 94% of fatalities. Again, this is consistent with other literature and other state and country data revealing older ages being most at risk due to COVID-19. And for today's healthcare utilization numbers from April 22nd, from yesterday, available as of today, total COVID-19 individuals currently hospitalized with COVID-19 is now 15,021. This is a decrease in current hospitalization of 578 from the day prior. Please note, though, although the currently hospitalized number is decreasing, we still continue to see admissions to healthcare facilities at a 1,359 number, and that has plateaued for a few days. So there is still a significant number of individuals admitted and hospitalized with COVID-19 on a daily basis in New York State. ICU admissions, current total is 4,597, which is decreased by 93, and intubations of those in the ICU is 3,918, decreased by 16. So again, we are seeing decreases in these numbers, which is a positive finding. Deaths, the total already noted at over 15,000 for April 22nd, 438 deaths, sadly. That's 403 in hospital deaths and 35 in nursing homes. This is, though, reassuringly 36 less deaths than the day prior, and that has continued to decrease slowly as well. So now let's delve into some updates as far as SARS-CoV testing for the coronavirus disease COVID-19. We've spoken quite a bit about testing, and Governor Cuomo has spoken quite a bit about testing expansion strategies over the last number of weeks. And so just to categorize these into three different categories. The first critically important testing strategy and an aim for expansion moving forward is in the testing, tracing, and isolating strategy. So we need rapid availability of molecular testing for individuals, particularly as we reopen, although this has been an emphasis throughout this outbreak. But as we reopen, we need to continue to expand our capacity statewide so that we can rapidly test and then rapidly trace these individuals, do contact tracing, isolate those who are infected, and have those who are close contacts of the infected go into quarantine to prevent spread of this disease. Additionally, due to concerns about health disparities starting today in public housing settings in New York City, the New York City Housing Authority, in partnership, will engage in increased testing efforts in communities in the city, and expansion will happen thereafter in minority communities statewide, including within public housing settings, as well as engaging in partnership with faith-based organizations. Additional areas of testing expansion include the necessity, and we've spoken about this last week, to test for antibodies for those who have been previously infected with COVID and can potentially donate for convalescent plasma clinical trials. And finally, testing can inform our reopening strategy. And one way to do that is to do community serosurveys to have a sense of how many individuals in the community may have been infected to date. And we'll speak a bit more about that in a moment. For the first item of molecular testing to rapidly test enhanced contact tracing, isolation and quarantine to prevent spread, we need molecular testing. And this is an old slide that I've shown in previous weeks, but again, to highlight that we have continued to encourage that when patients do not require clinical care in a healthcare setting, that providers can send them to alternative specimen collection sites for COVID-19 testing where available and where feasible. These continue to be expanded statewide, both from state-run sites as well as those involved in healthcare facilities or private practices and involved and run through engagement with local health partners. As many may have seen in the lay press, Governor Cuomo did go to the White House yesterday and is working with the federal government to continue to work on expansion of molecular testing statewide in regards to the needs that all of our clinical labs and commercial labs have for improved availability of reagents. And that is an ongoing area currently. And again, here are some links on this slide for the New York State Department of Health COVID website, which can highlight any available specimen collection sites and how to access. And primarily, the individuals can call the New York State Department of Health COVID hotline at 888-364-3065, or engage with your local health department partners to find out what might be available in your setting. Commercially available molecular assays is another area, as many of you are aware, of availability of testing and for expansion of molecular testing. So each week we've showed this slide and we see more and more available FDA-approved molecular assays each week. We're now up to 40 from last week being 33 PCR-based assays for SARS-CoV-2 that have been fully, approved through the FDA's EUA process. The majority of these are assays that can be used in a high complexity lab, and there are 3 waived assays which may be used in a high or medium complexity or near a patient care setting. As noted, though, there are many supply chain issues for reagents. And previously, we've had questions from healthcare providers about home-based testing. That's been a hot topic that's come up. And on previous webinars, I presented that there was no availability commercially nor FDA-approved home-based testing option. Now, today, I will present a couple slides on a LabCorp home testing kit option called Pixel by LabCorp. This is not a commercial endorsement, but again, for the sake of sharing, as we have had many questions about this, we would like to share this new update that this is now available nationally. The FDA has recently approved LabCorp to use an at-home collection kit for SARS-CoV-2 testing for use under an emergency use authorization. The Pixel by LabCorp Test Home Collection Kit will be used for self-collection of a nasal swab specimen, and then the specimen is sent to LabCorp for testing by a PCR technology. The collection kit that is sent to the individual includes a nasal swab and saline tube for the nasal swab to go into, so the collection materials, insulated specimen pouch, gel pack for sample cooling, specimen biohazard bag, instructions to direct the home users on how to collect the nasal swab specimen and place it in the tube and package and ship it, and a pre-labeled FedEx return envelope. So how does one get this test? It's currently not yet commercially available in New York State. However, when it is available, the process looks like this. A person goes online and fills out an eligibility survey. The kit will only be dispensed to patients meeting the inclusion criteria based on the information provided through the website questionnaire and reviewed by the Physician Wellness Network. This network will determine test eligibility and write the prescription for the testing. And an eligible person can go online and purchase the collection kit, and it's then shipped via FedEx. The inclusion criteria are healthcare workers or first responders with mild symptoms or high-risk patients with mild symptoms. Exclusion criteria include patients with no symptoms, low-risk individuals, or individuals with severe symptoms who will be directed to seek immediate care. These are the inclusion-exclusion criteria per LabCorp as of 4/17/20. And you'll see here on the slide on the left a picture of the the instructions that come with the kit and are mailed to the patient. And you can see here, there's a picture of a nose on the sort of second row all the way to the right, which shows that the swab is inserted just into the anterior aspect of the nose, of the nostril, and then they are instructed to rotate that swab. A little more information here. So as physicians, as healthcare providers, we want to know what is the sensitivity and specificity of this product. The specificity on empirical testing in the lab seemed to indicate that it was fairly specific and showed that all targets were negative for all tested microorganisms except for the SARS coronavirus that was expected to react with this target. So in other words, it did not cross-react with other human coronaviruses, such as those that cause the common cold or other common respiratory viruses in the lab. Sensitivity, there was in-lab analyses of sensitivity. However, I do not yet have a great sense of the sensitivity in the clinical setting as compared to the gold standard, and we hope to see this information to be forthcoming as this test is used in communities moving forward. The person would self-collect, again, a nasal swab sample, place the swab into the tube containing saline, place the tube in the bag, ship it with a gel pack with the pre-addressed label, and then LabCorp would perform the PCR test. The individual, the physician network, would follow up all positive and inconclusive tests, and as well as notify individuals of negatives by email, phone message, or through a website portal. As noted, this is not yet available in New York State. However, we are working to make this available to residents of New York State as soon as possible. And again, forthcoming information on full sensitivity and specificity and how to best use this home kit should be coming forward in the days to come. However, in the meanwhile, we do recognize that this is an opportunity for individuals to have testing in a setting that does not burden the healthcare system nor expose others to potential illness in the healthcare facility setting, nor utilize excessive amounts of personal protective equipment. So there are some valuable aspects to the home testing paradigm. Other available serologic assays commercially, as mentioned in previous weeks, there are a couple different categories on the FDA website, and this is critically important to understand. So antibody-based assays are being developed at multiple labs. 4 assays are FDA approved for use in moderate or high complexity labs. 3 of these are either IgG and IgM, or total antibody tests, and 1 is FDA approved as an IgG-only serologic assay, that is a Mount Sinai laboratory. We in the New York State Department of Health recommend using only for serologic assays FDA EUA approved tests as these ones noted, and the link is available to you there on this slide, or a New York State approved test such as the Wadsworth Center New York State Department of Health Public Health Lab serologic assay. Please note that there are over 70 other serologic assays listed on the FDA website, which are listed there but not FDA reviewed nor approved. And so we do not recommend the use of these tests as they have not been approved and reviewed by the FDA. A negative does not rule out SARS-CoV infection, and a positive does not rule it in as it could be related to cross-reactivity, and the information is not yet fully reviewed and approved. Now, on our webpage, we also have information available to you in the testing section of the webpage regarding the Wadsworth Center's assay for SARS-CoV-2 IgG. So this is an IgG-specific test, and I'm sharing this information in the question and answers here. As mentioned, there are individuals in the community who have been given this test as part of a community sero survey. And so this is important for providers to be aware of these available resources on the webpage describing the test characteristics and what we know about this test to date in order to be able to assist patients in understanding what their tests might mean. So this is an IgG-specific test. Blood can be collected using a dried blood spot card. And infection with SARS-CoV-2 does seem to result in the production of IgG antibodies, but it is not yet clear exactly when and exactly if that happens to everybody, including those who are fully asymptomatically infected or have mild symptoms if it's the same degree as those with more significant symptoms. There is a lot to be learned still. A reactive result on this test indicates that IgG antibodies to SARS-CoV-2 are present in the blood. A reactive result may be due to past or present infection, as with other infectious diseases when an IgG is positive. But it is possible that there could be some cross-reactivity in theory to non-SARS-CoV-2 strains. However, the specificity for the Wadsworth Center test has been determined to be 93 to 100%. Therefore, significant cross-reactivity to other known respiratory viruses is not expected. A non-reactive result in this test means that IgG antibodies were not present in the blood. However, as with any other antibody test, if early in disease in the acute phase, convalescent titers should be checked later, or while in the acute phase, molecular testing should be performed to look for acute disease. Some questions that have been received: is a person with a reactive result on this test immune? And this just won't be known until we have people who have IgG levels who are exposed again, and we can study whether any of them are infected again. So it is not known at this time. It is also not known how long these IgG antibodies will last. It will take some time to find these answers. When should this test be used? The test should not be conducted until at least 21 days have passed since the symptom onset or the positive molecular diagnostic test, to give time for antibody development. And can a healthcare worker who has a reactive SARS-CoV IgG test return to work? Well, it is not known whether having IgG antibodies mean that you're still infectious or not. And it's not known the immunity status, as mentioned. So individuals who are healthcare workers need to follow the New York State Department of Health guidelines on healthcare workers returning to work. And that has to do with evaluating a resolution of symptoms and a certain time that has passed, at least 7 days and at least 3 days without fever, etc. It is recommended that healthcare workers continue to follow the current COVID-19 infection control precautions, including continuing to wear full PPE as recommended. And this test is not required to return to work. So now to briefly talk about statewide community serosurveys, which have been conducted over this last several days. And this information is hot off the press. So please be aware that this is preliminary findings. These are likely to change with further results coming in and any further evaluation and interpretation and analyses. But for the sake of sharing for our knowledge as healthcare providers in the state, I'll review this hot off the press information. What was the aim of the statewide community serosurveys? To develop a baseline infection rate, to have an understanding of the prevalence of this infection in our communities and in different communities throughout the state. So over 3,000 people statewide were tested over 2 days in 19 counties at over 40 localities. This was only ages 18 and over. Individuals were tested with a dried blood spot test at grocery stores or other similar stores in an attempt to obtain a random community sample. Preliminary results reveal a statewide positivity rate of nearly 14%, and as expected, with a range in different settings throughout the state. New York City at 21% positivity, Long Island 17%, Westchester, Rockland counties nearly 12%, and the rest of state at 3.6% positivity. And so what do we do with this information? What does this mean? If the infection rate is at this 13.9%, and again, this is preliminary data, case fatality rate may be lower than prior estimates. It could mean that 2.7 million people have been infected statewide. And with the 15,500 total fatalities in healthcare facilities, hospitals, or nursing homes, this, although please note, does not include at-home deaths or other deaths not identified as COVID earlier in the outbreak period or thereafter. So this is likely an underestimate of total fatalities. So looking at all of these factors, estimates of the case fatality rate may be approximately 0.5%. And again, this may be likely to change with further data and further analyses. What does this help us do? This helps providers like yourselves in different parts of the state get a sense of what they've seen and how many of their community members and patient population are still susceptible, and also gives us data to support a regional coordinated framework for reopening. And now a brief comment on containment. So contact tracing. So we've spoken about containment and contact tracing before. This is something that has been going on all along from the very beginning of this outbreak, with our excellent local health department partners leading the efforts and working tirelessly in this realm. Now, moving forward, though, if we want to ramp up and scale up, there may be need to supplement those local health department activities. And so there's a need for a large group and scale up of contact tracers to supplement those activities routinely performed with the staffing routinely available. And that's been referred to, as many of you may have heard in the lay press, as a contact tracing army. This needs to be coupled absolutely with the increased testing we talked about, because we can only trace and isolate those who are infected when they've been tested and identified as infected. And then we can only go after those contacts for quarantine if we know about those folks. And this can, again, help us to try to safely reopen and contain virus as much as possible after opening. Again, this is something that would likely require a regional approach. So moving forward, this statewide large initiative will be in conjunction with Connecticut and New Jersey. And Bloomberg Philanthropies has committed $10.5 million along with organizational support and technical assistance to build and execute this statewide program, and in conjunction with other states, and to identify and recruit contact tracer candidates, including New York State Department of Health staff, other state agency staff, and SUNY and CUNY health students. Bloomberg School of Public Health at Johns Hopkins University will assist in building the online curriculum and training program for contact tracers, and Resolve to Save Lives, an initiative of Vital Strategies, will provide operational and technical advice. All of this in conjunction with our routine contact tracing experts at the New York State Department of Health and in each of our local health department jurisdictions, 57 counties, and New York City Department of Health and Mental Hygiene. And now we usually speak briefly about community mitigation for the sake of being able to update your patients and community members on what's expected here. So New York State on pause and social distancing, again, seem to be working to flatten the curve, but we need to continue to bring this total case count down before we reopen. We are still at a fairly high level. We have passed the apex, which is reassuring, but we are still at a high level of daily infections and daily hospital admissions. And it is ideal to have that number go down before getting to the reopen phase. So this is extended through May 15th. Again, schools and non-essential businesses will remain closed. Again, an executive order was written last week, as of last Friday, requiring all people in New York State to wear masks or face coverings in public, and directing employers to provide essential workers with masks free of charge when interacting with the public. And again, all of these activities on reopening will be done in coordination with our nearby state neighbors. Guidance for masks for the public has been released and is available on our webpage. And I'll review this only because this is not something that we as physicians usually advise patients on. Obviously, this is a new thing to advise patients on wearing face coverings in public settings. So what are some of the pieces of guidance here? Individuals, so those over 2 years of age and those able to medically tolerate a face covering, must procure, fashion, or otherwise obtain face coverings and wear such coverings when they are in public and are within 6 feet of distance from others, or in a situation where they may be unable to maintain that distance, or on public or private transportation, or a for-hire vehicle. And that includes the requirement for both the passenger and the transport operator. And again, the essential businesses must provide these coverings for their staff. Facial coverings include, but are not limited to, cloth, either homemade, quick cut, or bandana, surgical masks, N95s, and face shields. And the CDC has some excellent information on their webpage on the different types of cloth face covers and other personal protective equipment that can be used, and instructions on how to use, clean, and dispose. But please note that although an N95 would be considered sufficient for this executive order, those respirators, considered some of the most protective PPE, remain a critical need for healthcare workers and first responders. And so those respirators should be prioritized for those settings. And again, always advising your community members and patients on these other key points that despite the mask, still staying home is critical, and making sure they fit appropriately, are changed frequently and laundered, not touching the face, and all of the other important pieces of information and guidance such as hand washing, alcohol-based hand sanitizer, respiratory etiquette, and social distancing. This is a repeat slide from last week as well, but important to note that the New York State of Health still has open enrollment for your patients and community members to apply through May 15th, although individuals must apply within 60 days of losing coverage. So important to note. And for infection prevention and control, just one brief update today. And this is about discontinuation of isolation for patients with COVID-19. This is for hospitals, nursing homes, adult care homes, and other congregate settings where populations vulnerable to COVID-19 reside. Because hospitalized patients or older adults may have longer periods of infectivity, and because congregate living facilities have other highly vulnerable patients or residents, this guidance is different than the discontinuation of isolation guidance for those in the community. This is a more conservative approach to protect those others in the congregate setting. So there's an option of a test-based strategy or a non-test-based strategy. And the non-test-based strategy, at least 3 days without fever, defined as it has to be lower than 100 without the use of antipyretics, improvement in symptoms, and at least 14 days have passed since symptoms first appeared, unlike 7 days for those in the community. If asymptomatic and tested positive, at least 14 days again passed since that first test. With a test-based strategy, that should not be implemented until at least 7 days have passed from the first symptom onset or that first positive test. And then additionally, these factors of no fever and improvement in symptoms, and then 2 tests negative at least 24 hours apart. Now, very briefly, over the last week, we've seen new guidance come out on therapeutics, guidance from the NIH, the National Institute of Health, Infectious Disease Society of America, and we also have a guidance available from our New York State Medicaid Prescriber Education Program. And these links are available on this slide to you to access any of these guidance documents on COVID-19 therapeutics. Overall, they're very consistent. Unfortunately, what we're finding, as many of you are aware, to confirm your suspicions on this, are that the NIH guidelines for COVID therapeutics, that there currently are no FDA-approved medications for COVID, although many medications are being studied in New York State, and you can look at these trials with this link for clinicaltrials.gov. In addition, providers can access investigational drugs through other pathways other than clinical trials, such as the Emergency Investigational New Drug Pathway or off-label use. However, these guidelines do not recommend pre- or post-exposure prophylaxis for COVID-19 outside of a clinical trial. And at present, no drug has been proven to be safe and effective for treating COVID-19. There are insufficient data to recommend either for or against the use of any antiviral or immunomodulatory therapy in patients with COVID-19 who have mild, moderate, severe, or critical illness. The Infectious Disease Society of America's guidelines, rapid guidelines on COVID-19 therapeutics, also emphasize an overarching goal of trying to have patients entered into ongoing clinical trials. And here, please note that they use the word only in their recommendations when there's a therapeutic agent with higher uncertainty and or more potential for harm. They had 7 recommendations made. Among patients who have been admitted to the hospital with COVID-19, the IDSA guideline panel recommends hydroxychloroquine or chloroquine in the context of a clinical trial. Among patients who've been admitted to the hospital, they recommend hydroxychloroquine or chloroquine plus azithromycin only in the context of a clinical trial. Among patients who've been admitted, they recommend combination of lopinavir, ritonavir, or Kaletra only in the context of a clinical trial. They suggest against the use of corticosteroids and recommend the use of corticosteroids for ARDS in the context of a clinical trial. Recommendation number 6 is for the IL-6 receptor inhibitors, tocilizumab, only in the context of a clinical trial. And for patients who are admitted, recommending convalescent plasma in the context of a clinical trial. And this slide was also mentioned last week, but just to review, since we've had many questions about convalescent plasma clinical trials, this is an investigational treatment being explored in several sites in New York State and based on data from other respiratory infections. Although promising, has yet to be shown to be safe and effective and hence needs to be under study. It's essential to study it in severe or critically ill patients in particular, and has not yet been approved by FDA. It is regulated as an investigational product. There are several pathways for this listed here and as described in previous webinars, and we'll move along for the sake of time. Now we have Dr. Marcus Friedrich with us, Chief Medical Officer in the Office of Quality and Patient Safety, to speak about healthcare system utilization and surge, elective outpatient procedures, and other information for healthcare providers.
Thank you, Liz, for this extensive review again. I just want to highlight a couple points around the telehealth. We are aware here at the Department of Health that this varies by payers and plans in the different regions. I just want to emphasize that when phone calls and videos have the same reimbursement, that is certainly good, and some payers are doing that at the same level. And if the phone conversation is lower than actually the video conversation, that is actually not so good and not as helpful. As you know, by now, a lot of patients are 4 or even longer weeks at home, and a lot of patients have a barrier on getting on a video with their physicians, and then having the physician being penalized for that is certainly not in the interest of the providers and so forth. So we would urge again, and we are looking into that here from the Department of Health to help kind of facilitate a discussion to make these payments and reimbursements at par. I again put up a couple of I think guidance links that I think are useful. I checked those links earlier today. Again, the American College of Physicians have a great telehealth resource talking about reimbursement and so forth. The CDC has this really excellent outpatient ambulatory care setting guidance that we also have in our weekly provider compilation, which really goes into detail and talks about telehealth at the end, about national resources that you can address, but also then Medicaid again with this extensive program update, and a very extensive document that really goes into the details of telehealth. There is also, we are aware that there are a lot of practices doing and operating these specimen collection site in their facilities, and we certainly over the last, I think 2 days ago, have published guidance around this. We just want to make sure that the healthcare providers are safe, that the patients are safe, and that this is done in a safe manner for everybody involved to prevent exposure for COVID-19. We divided it into if you can do it, it's probably preferable to do it outside, because inside you actually need this OSHA compliant ventilation. That means probably negative pressure rooms, and or ensure that patients are 6 feet apart from each other and so forth. So outside is certainly the preferred area and so forth. And then also how to ensure that the staff is safe with PPEs and so forth. So if you have a second, it is on our website. We have a link also on our provider compilation that talks about that. And I think it's it's useful information if you are thinking in your practice to set up kind of a collection site. A couple words towards the surge response. As you know, and Liz mentioned that earlier, that the current net hospitalizations are down. That includes also the ICU stays of patients, and the intubations are down. But Liz also mentioned earlier that we still see hospitalization. So that does not mean nobody comes to the hospital anymore, and we got to be vigilant. And although the numbers are going down, there is still, in need, and over that some of the hospitals, especially in the downstate area, are at capacity or even above that. The two major alternative sites I just want to mention is the Javits Convention Center in New York City. They have little over 170 patients right now, and then the USNS Comfort that has currently 48 patients, and a lot of them actually in the ICU. And then there are other alternative sites, the Health and Hospital, New York City Health and Hospitals. They have the Billie Jean King Tennis Center. Mount Sinai has the Samaritan's Purse. Maimonides has Crown Heights, and New York Presbyterian have the Larkinfield Hospital. All these are really great examples to decant and help especially downstate facilities to deal with the amount of patients that they're currently having. We're hearing still a lot, and there's no denial about that, the PPE shortage. I just want to again emphasize that we from the state, we are supplying down to the counties, and please contact again your local county OEM. We also have a link on our website, but also on the compilation. And we just made another shipment yesterday down to the county. So there is PPE supplies available for providers. Work towards volunteering. Again, thank you all who put your name forward on that. The providers, especially in the downstate area, but everywhere else I talked to, are exhausted. Everybody thought by now this would be over fast, but it's not. The governor reminds us almost on a daily basis that this is not a sprint, but more like a marathon. And so if you know of somebody who can volunteer, please direct him to our website. We are in dire needs, and that's been shown throughout the hospitals for dialysis nurses, but also dialysis techs, because a lot of these patients are actually developing acute kidney injury. And then, of course, in our nursing homes, our colleagues in the nursing homes, there are severe nurses shortages, and we are really looking for volunteers who can help to support the frontline staff in the nursing homes there. Couple words towards our provider document. There is, if you haven't gotten it, there's this email address that I just want to repeat, COVID provider info@health.ny.gov. And also we have it on our website, coronavirus.health.ny.gov. And there's a provider tab, and the provider compilation is right on there. We updated a couple of these guidance documents, also what Liz mentioned on the face covering, telehealth resources, and there is a new section of outpatient and ambulatory care setting guideline from the CDC, and it's really a pretty good compilation of a couple of high-flying points, making sure how to prepare for a surge, how to prepare for a PE and staffing shortage, and so forth. So it's really worth taking a look at it. Another thing that I want to mention, which is very close to my heart, and I know a lot of people here at the department, but also across the state, with the fact that a lot of downstate hospitals are over capacity, there is a goal to provide expecting mothers with safe alternatives, and we've seen issues with that in the past. I just want to make sure that you know that DOH is working with the Secretary of the Governor, Melissa DeRosa, but also with the New York State Council on Women's and Girls and the COVID-19 Maternity Task Force to think about best approaches to authorize and certify additional dedicated birthing centers. I think this is a vulnerable population that needs to be protected to the best that we can, and providing and thinking about additional birthing centers is certainly making sense. And then the governor announced 2 days ago that under certain criteria that there could be elective outpatient treatment and surgery starting April 28th in selective counties. There are certain county criteria that are based on new COVID-19 hospitalization, but also the hospital capacity in the county. And then there are certain hospital criteria that highlights, again, the hospital capacity. And although it was at least in the governor press release, just mentioned for hospitals, but there is the question if it should count for ambulatory surgical centers and office-based surgery, as well as the diagnostic treatment centers. And we are working currently here at the DOH to put out a guidance to clarify actually what that means and how we can safely restart some of the elective surgery in certain counties as well. just want to emphasize, the compilation document that I already did. And this is basically it, what I just wanted to go into. Liz, if you can take it over. I think we have a couple more slides on the resources before we go into questions and answers.
Yeah, and we don't have to spend very much time here. Again, the CDC resources here available to you with a link. The New York City Department of Health and Mental Hygiene, the Office of Mental Health for New York State, with several resources, including some handouts that are useful to give to patients or community members, and our New York State Mental Health Helpline. That is 1-844-863-9314. Again, these resources are listed here at the end as a reference, but this one in particular, we know that this has been very hard on many individuals, including healthcare workers. Mental health hotline is at 1-844-863-9314. It's staffed by trained volunteers, mental health professionals who have volunteered, who've received training and crisis counseling related to the mental health consequences of infectious disease outbreaks, stress reactions, anxiety management, coping skills, and telephonic counseling. On the next slide, I would like to emphasize that on Wednesday, April 29th, MSNY, the Medical Society of the State of New York, has a Medical Matters webinar at 7:30 a.m. and then available thereafter via a webinar link on COVID-19 for office-based physicians, how to handle surge and the psychological impacts and psychological first aid. And then we have here just some screenshots of useful resources on our webpage and available links. And where to call or where to go for questions or concerns. Now we can turn to a little bit of question and answer.
There were a couple of really interesting studies coming out the last couple of days. One of them was in the New England Journal of Medicine, kind of an observation in the correspondence section about the universal screening for SARS-CoV-2 in women admitted for delivery. Can you make a couple comments on that?
Yes, this was an excellent paper published out of our New York Presbyterian partners in the city, and what we saw there actually is it's about pregnant women and women going to the hospital for labor and delivery, but really supports the other data already shared on community serosurveys. So at Columbia Hospital in Manhattan, New York Pres Columbia, they found a prevalence of about 15% among women coming in for labor and delivery of positivity on molecular testing for COVID-19. 88% of these women were asymptomatic. So that was a pretty striking finding in that New England Journal paper. Also, an article out of Winthrop Hospital found a prevalence of almost 20%, 66% of whom were asymptomatic, and that's in the American Journal of Obstetrics and Gynecology. So again, pretty striking findings here in both of those papers in pregnant women, and I think with implications for the community at large. I would like to ask you, Dr. Friedrich, there were some other papers in the New England Journal from NYU, or more recently, an excellent one with large numbers out of the Northwell Health System published, I think, just yesterday in JAMA. Can you provide any comments on that?
Yeah, I think these are my former colleagues from Northwell. It's a case series of patients, 5,700 patients in their 12 of their hospitals, mostly in Long Island, Westchester, and in New York City. And I think what is striking is that a lot of these patients who were admitted, they had a lot of comorbidities. At least, if I recall correctly, that more than 80% had comorbidities, more than one comorbidity. 50% had hypertension, a third diabetes. But really, they then did a subgroup analysis of for outcomes, and they took 2,600 patients, and about 15% ended up in the ICU, and of those, about 80% were intubated, and of those intubated, about about 88% actually expired on the ventilator. And these are like findings that are significantly higher than numbers that we've seen in Wuhan, but also out of Italy. And this is really, the question, I think, in the ICU community, where we in the Department of Health are also very active about, does it is it still true that we should early intubate or wait later with intubation? There's a lot of talk about high flow oxygen that was tested in Wuhan, but you need, of course, negative pressure rooms for that. So there's a lot of unknowns, especially in this most sick patients in the ICU setting. And we will try to, and I think there will be more studies coming out in the future on that. So I think this is really, and that was published in JAMA, I think, overnight last night, as you said correctly. It's certainly worth a try or a read because it really focuses in on New York State and the issues there. I have a couple other questions, just in the interest of time. We have, I think, 3 minutes left. We talked about immunization last week, on adult, but also the pediatric. There were a lot of questions about what is with, our children who are going to school, and, what is the latest guidance on that for practitioners?
Yeah, so that's a great question. As we talked about last week, we really want to prioritize for our well child care those infants and children up to age 24 months to get those primary vaccines that are so essential in that high-risk population, and to give those vaccines safely. And so that is just to reemphasize a priority that we talked about last week, and there are several organizations out with consistent guidance on that. As we start to look forward to a reopening at some point in the future, this question has already started to come up about school-based immunization requirements, and that those guidelines and requirements will be forthcoming, and hopefully we will have time at future webinars to go through that information once that is available.
Great. Thank you, Liz. The last question that I want to ask you, and this is personal because my wife asked me that and I don't have a good answer to that. One of her patients got tested a few weeks ago and was positive for COVID-19. And then she got, for some reason, retested 4 weeks later, as recently, and was tested again positive. How can that be? I thought that the molecular PCR assay is really just picking up, the acute phase of the illness. But if after such a long time, have you heard about? Do you have an explanation for that?
So there's a lot of talk about this. We're both seeing this here in New York State, as well as there is anecdotal reports out of other countries in China and South Korea and Italy, as well, of similar findings with positivity out beyond 1 month into 60 days even. So this is an important area that needs further study. There was one very small study in Germany of, I believe, 9 individuals. We can share more at a further webinar, but out of this very small study, it was identified that the virus farther out may not be infectious and may not be replicative virus in the lab when attempting to grow on viral culture. So we clearly need more study in this realm, and so more to come there.
Again, Liz, thank you very much. And thank you all on the front line, supporting your patients, but also all the work that you're doing. And stay well, stay safe. And with that, have a good afternoon.
Thank you very much.